Hi, this is Melissa Ayers. I'm going to talk to you about multiple sclerosis and the nervous system. This is for Nurse 5103, Nurse Educator Role Development Online, Mr. Piankos, due October 4th, 2024. So let's get started. Our patient is going to be a 45-year-old firefighter in a large city, so he's very physically active. He has a dangerous job. He breathes in lots of chemicals. He uses a respirator. He's very healthy. He has no medical history to report other than when he was 16, he broke both his femurs in a car accident. He reports that he eats healthy foods. He works out regularly. About 2 to 3 weeks ago, he said he started having trouble memorizing. His short-term memory started to kind of fail him. He experienced strange loss of coordination. He said his hands just kind of won't go where he wants them to go. His legs feel really wobbly, like at times he just can't depend on them. Afraid he's going to kind of stumble. It's really invoking anxiety in him. He's not. He's anxious about the situation. Overall fatigue, generalized weakness. He's having episodes of urinary frequency. He works out regularly. He does not smoke. He does drink alcohol socially. He is married. He is sexually active with one partner. Family medical history includes a mother with breast cancer. She's a survivor. Father has autoimmune issues. However, he doesn't know the name or the specifics of the issues that his father has. Grandparents are both deceased from a plane crash in the early 1980s. He states he doesn't really remember much about them. He does report over-the-counter several protein supplements, pre-workout, post-workout, and he does report that he uses CBD oil for post-workout recovery for the soreness. So as you'll see, a lot of these signs and symptoms can lead us to think many different things other than multiple sclerosis. My mind wouldn't immediately go there. So multiple sclerosis can have a very sneaky onset. So a lot of the testing that they do to decide on it being multiple sclerosis is basically rule out. There is no one test really that will point you to a diagnosis of multiple sclerosis. What you do have is several tests to rule out what it's not. So we would do a CBC to rule out any infection or to, just to rule out infection. A serum copper level to rule out Wilson's disease. Wilson's disease is a buildup of copper in the system and it causes many different issues. We could do a serum B12 and vitamin D levels. That would rule out any abnormalities or missing nutrients in the system that may cause a reaction. We could do a TSH to rule out any thyroid conditions or abnormalities, because as you know, thyroid can lead to a lot of different diagnoses. Hypothyroid can lead to the fatigue, the muscle weakness, the memory loss. All of those things can be grouped into a TSH result. We could do an MRI of the brain and spinal cord, and we would be looking for any abnormalities in the brain stem, and the spinal cord. We would be looking for everything being intact, no swelling, no loculated swelling, just normalcy. A possible lumbar puncture to rule out any infection in the spinal fluid. Because that could definitely lead to some issues, any kind of meningitis or anything like that. So different tests that we would could order would be an ANA, or an anti-nuclear antibody test. That is to help diagnose severe autoimmune diseases such as lupus or CREST syndrome. So the purpose of that test in trying to diagnose would be to rule out lupus or CREST syndrome, and to help point us at an autoimmune or an inflammatory disease. So once we ruled out lupus and CREST and we still had an elevated result, we're still looking. So then we move to the ESR, or the erythrocyte sedimentation rate. So that looks for aids in diagnosing sediment rates in the blood due to cell destruction. That comes from inflammatory processes. So if we know we have an inflammatory process, we don't have a diagnosis of multiple sclerosis, but we know something's going on and we've got some inflammatory processes. So now if things haven't already, they should start clicking to where you're starting to think there's something big going on here. So further, we could do a CCP, or a cyclic citrullinated peptide, and that tests for rheumatoid arthritis. Again, autoimmune inflammatory disease. So if we think we have rheumatoid arthritis, we do our CCP, we know we've got something inflammatory going on. So if we ultimately rule out rheumatoid arthritis, but again, we still have inflammatory processes present, we're going to keep looking. Okay. So in the review of systems, as we are going through and examining our patient, we're going to see constitutional symptoms of generalized weakness and fatigue. HEENT, he has episodic blurred vision and increasing memory loss. All other systems are normal. Cardiovascular is currently negative. He has no cardiovascular symptoms. Respiratory, currently negative. He's breathing great, lungs are clear. Nothing to report there. Gastrointestinal, negative. He's not having any trouble. He's having regular bowel movements. He eats healthy, like I said earlier. No issues there. Genitourinary, he is having episodic urinary urgency. He reports that he could be working out, having just went to the bathroom, and then all of a sudden it feels like he's going to pee his pants. Or he doesn't feel like he has to go at all. All of a sudden it feels like he's going to pee his pants. So he said when it comes on, it is very urgent, and it feels like his bladder is full. Okay. So musculoskeletal, we had positive findings. So a review of the musculoskeletal exam supported the complaint of muscle weakness. Upon exam, the patient did show unequal upper and lower extremity strength. His grasp for the upper extremities was left greater than right. Lower extremities was left greater than right also as far as strength. The exam further revealed some spasticity in all four limbs. The neurological exam revealed decreased vision acuity, resulting in blurry vision. The patient reports a sudden onset about 2 weeks ago of no previous vision abnormalities. Of note, there seems to be abnormal tracking in the left eye, so I know that my left side is the most affected. A psychiatric exam reveals a very present anxiety concerning his current health issues and the sudden onset of these symptoms. He has a feeling that something is very, very wrong. So as a practitioner, that should speak to me as well. That should tell me something's going on. My patient has this impending feeling, not so much of doom, but just that something is very wrong. All right. Endocrine, negative. We didn't get anything. Our TSH was negative. Hematologic, negative. We didn't get anything crazy there. Let's see. So pathophysiology of multiple sclerosis is that it can be a very debilitating disease. It is known to be an inflammatory disease, like I said earlier, but it is not known what causes it. We know that the body attacks the myelin sheaths of the nerve fibers, and that causes there to be holes in the nerve fibers. Those fibers are needed for effective communication to travel through the nervous system. So when those fibers are damaged, it's like somebody took a link out of the chain and the communication is dropped. It can't make it all the way to where it needs to go. So then the body doesn't receive complete messages, whatever that message may be. When it comes to muscles, it would be contracting and releasing. So if they are not receiving their messages, the body kind of will get a little spastic and just do weird things that you're not used to. So it interrupts that nerve communication. The holes in the nerve fibers are called plaques, and you don't want those plaques. What you can tell, plaques are the hallmark of multiple sclerosis. Outward symptoms that you get, say, let's say loss of coordination. That should direct you, once you have a multiple sclerosis diagnosis, where to look in the body for the attack. So if we had discoordination, we might look in the brain. It can attack the brain and the spinal cord. So what's happening outwardly kind of tells you where to look inwardly. All right, so as far as pharmacology, they mostly use disease modifiers, or they treat the symptoms. There is no medication to cure it. There is no cure for multiple sclerosis. There are medications that can treat the symptoms and try to help prolong the quality of life for these patients. It can be a very slow-moving disease, or it can be a very fast-moving disease. It just depends, and when I say that, we don't know what it depends on. Some people just have fast moving, some people have very slow moving and easily controllable. So some of the medications that are used currently would be interferon beta 1A and 1B. That decreases inflammation overall. These are short explanations for a very long process. Glatiramer is a peptide that resembles the myelin proteins. So while it doesn't fix completely that nerve fiber, it does assist with the communication by mimicking those nerve fibers. It doesn't fill it in completely. It is not a cure for this disease. So then we have sphingosine. It alters lymphocyte migration. So it keeps the lymphocytes in check, and it keeps them from attacking or pooling or doing anything like that. Teriflunomide, again, deals with the lymphocytes. It affects and prevents them from concentrating, because we don't want them to concentrate, because if they do that, then we've got another issue. Delfapridine is a bit of a wonder drug. Delfapridine is the first drug of its kind that improves walking speeds for MS patients. So that tells me that it provides a level of coordination that maybe they had lost previously. Okay, so that's a great drug, the first of its kind. And it does that by preventing potassium buildup in the muscles and in the system. So it allows them to continue to control their muscles a little longer. So as far as questions, the questions that I've proposed are: what would your nursing care priorities be for a 20-year-old patient with newly diagnosed multiple sclerosis and rapidly increasing paralysis? And number 2, after reviewing this case study, what would have been your red flag that something was happening with the central nervous system before testing, and why? And then we go into our references. I had the American College of Cardiology. I used Bite Size Bio, Crowley, Kuchnitsky et al., Dickinson J., Van Leeuwen and Poltes Lath, and Wayland K. Thank you for your time.